Thank you, Professor Hesham. And I feel actually obliged to congratulate you and all the parties that have been involved in such a successful and impactful campaign in Egypt, which you and all who have been involved should feel extremely and super proud of. We should also, I feel, also acknowledge the magnificent job done by Meredith and her team at the Endocrine Cancer Patient Advocacy in Australia on how they were able to deliver the essence of advocacy for better quality of life through such simple and practical tools and processes. So thank you again, and thanks for all our distinguished speakers today. So let's first start with Meredith. And here, Meredith, being the head of the patient advocacy in Australia, how would you report the outcomes when patients advocate for themselves in a way that can express and improve their overall quality of life with cancer?
Thank you, Reem. I don't know how many times I've actually had to say to patients, or had patients say to me, that when they fill in a pre-consult survey, it only sits on the desk and doesn't get looked at by the doctor during the appointment. So there's a lot of information about medical world with its own culture of authority, and traditionally doctors expect to tell patients what's best for them without their decisions and judgments being questioned. But today, thankfully, many physicians are more open to what advocates call shared decision-making. And in doing that, patients need to understand the quality of life tools and use them to express themselves in a clear and informative way. It's also to understand and express what is important to you, the patient, what you want to achieve, and prepare your questions before you go to the consult, so that it's like an agenda, a meeting list of things that you want to talk about. When you're utilising the tools, they should be things that can be scored and evaluated so that they're effective. Also ensuring that when you do advocate for yourself, that the clinician acknowledges your data, reads and discusses what you've reported, making a point of highlighting the most important points to you. And by having the report in a user-friendly format, it's a lot easier for discussion and visualisation by you and by your clinician. So by patient engagement, you can inform yourself and the patient and provider with education and policies, as well as enhance service delivery and the governance. Thank you.
Thanks a lot. Thanks a lot, Meredith. And I think we can move now to Dr. Mervat, who wears two hats today, being a professor of hematology and being also a leader of the ITP patient advocacy group in Egypt. So from your experience, Professor, what were the difficulties that you faced at the beginning of driving quality of life as a concept, and how were you able to overcome them?
Thank you, Reem. Assessment of quality of life is very important, and it needs to be stressed that it is important for the patient. The patients need to gain control of their quality of life assessment tools. We need to explain to them the quality of life assessment in very simple words, so that now they can help us rather than fill in just forms. The human aspect is very important. Once they understand that this can have an impact on the way of treatment and the durability of the treatment and when to change treatment, then they help you and remind you that before you used to ask me about such and such, now it is better or it is worse. And they know that together we can help each other reach the right type of treatment for their well-being and health.
Thank you, Professor. And now, from a different angle, let's move to Professor Mahira, touching base on real-life experience where patients might wait for more than 2 hours to only have less than 15 minutes with their treating physicians. So how can this quality of life discussion happen, Professor?
Thank you, Reem. And I think I will start from where my colleagues ended. Now we've gone a long way into this, the idea of quality of life and the shared decisions. But the problem is a lot of physicians do not have the concept of the quality of life. They don't need to listen to their patients. They have to understand that their patients have feelings and emotions which are much more important than their actual disease. Like I always tell my junior physicians and students, you treat people, you do not treat diseases. So first of all, after the patient has waited 2 hours, he becomes really disappointed if the physician doesn't listen to him. So we have to train ourselves in those 15 minutes to prioritize and listen to how the patient feels and what are his most important fears. And especially in dermatology, our diseases are very chronic and very long history. And I need to follow up my patient very carefully, mainly talking about how my patient feels about his disease, feels about himself, how is he handling his problems, how is his family coping, and especially we have a part of the disease that occurs in children, which affects the whole family. So I think this is the future. Thank you very much.
Thank you, Professor. And last but not least, our last question is addressed to Professor Hesham, being the leader of the national health campaigns, presidential health campaigns in Egypt. What's your advice, Professor, for the patient advocacy groups to be more engaged and to have effective collaboration with the governments and health authorities to become, like we say, indispensable partners in driving patient advocacy campaigns and to share in health policy decision making, from your point of view?
Thank you very much, Reem. Really very important question, because we need really a truly representative patient representative from patient advocacy groups. So it is very important to be really representing. So it is important to select all the patient. We advise the patient advocacy group to try to select the representative of this group to be more knowledgeable. And also it is important to go for advice, to have very good skills, especially in the language, so the native language and the English language. So it helps more to discuss, to go for the important areas, including the clinical trials, the side effect, the quality of life. So it is very, very important to go for selecting the right one, to go for really representing the patient group. The second thing, which is very important also, is trying to educate and to discuss this patient's representative about all the issues, including the awareness, the early detection, the treatment. So it's better to educate them, to include them in all these steps, as we tried now in the national campaign, to present and to attend this patient's representative in all the elements, including all of these, and also to discuss the clinical trial, the side effect, the quality of life, and other issues. And also, I suggest for collaborative activity and to try to avoid the fragmentations between different patient advocacy groups in the nation. So it is very important to collaborate between different patient advocacy groups and also cross borders. So it is important for all low middle income countries and patients with large population to go for like a platform for collaboration, even if it's a virtual platform, but will help more and more to go for a very good collaborative activities and filling the gaps if there is some gaps in between different groups. And I think by this we can go for like good representation for the patients in the different between the policy making and, as Meredith said, between the policy making and the patient groups.
Thanks for the indispensable advice, Professor Hesham. And we're looking forward really to have more patient engagement in the health policy decision making in across the whole Asia, Pacific, Middle East, and Africa. And now I think we still have time for some questions that have been casted by our audience so far. So let me start with one. The last one that I can see here is maybe it can be addressed to our physicians here. So the first who's going to raise her hand or his hand, please take that question. The question is, how often do local cultures interfere with patient therapy? So Professor, Yeah, Professor Mahira, please go ahead.
Now that's because especially in dermatology, maybe my colleagues, Professor Mervat and Professor Hesham, have more serious problems to deal with. But in dermatology, everybody tries local therapy first. And you have a hard time sometimes to convince the patient to get on the treatment or the systemic treatment you need, because he's convinced completely that those therapies are not going to benefit him, and he's going to do very, very well on local therapies. And actually, of course, this improved a lot. It's more in rural areas than in more urban areas and educated areas. But actually, for example, I'm a member of the International Psoriasis Council. They're thinking about doing studies along the low-income countries and these areas where they use their traditional therapies and do a proper clinical trial and proper study, because we might actually benefit from them. Because sometimes the patients do not want to, and I'm on several patients groups in terms of those thoughts about trying new medications. They all are local. Some of it might be beneficial, but in a lot of time it might interfere with the proper treatment and well-being of the patient. One very quick comment on Professor Hesham ElGhazaly. We have a big platform, for example, in psoriasis, to all, it's called IFPA, the International Federation for Psoriasis Association. It's a huge patient group. And I think it includes everybody, especially, it's a big, big platform. And I think what you're saying is extremely important. And thank you very much.
Thanks, Professor Mahira. Now to the next question. I think it's perfect, perfectly fits Meredith. So the question here is, how can patients advocate for themselves in countries where no strong patient advocacy groups exist for specific disease areas? And as we can see, cardiovascular, we are suffering from the absence of cardiovascular patient advocacy groups across our region here.
Well, I mean, I can speak from the cancer perspective, and especially with International Neuroendocrine Cancer Alliance, INCA. With the lack of advocacy groups, I think it's actually patients becoming aware of what is around. And even if it's not in their own country, then they can tap into other countries as well to get ideas and information. And I know with INCA, that there is actually the opportunity for patients to be members there to get more information to assist them in self-advocating and also getting more information. So I think that there's a lot that people can do. I think it's just actually being able to be their own advocates and go and look. I know that's always difficult for a lot of people because they might not have as many resources available to them. But I just think there is a lot of help out there. It doesn't have to be within their own country, that there's a lot of assistance that's out there.
Thank you, Meredith. And I'm here just highlighting again the QR code and the link for the well-being tracker that was shared during Dr. Rania's presentation. It's a very good tool. It's available now in English, but we can work on translating it into different languages that can be helpful in the local countries. Now for the last question, and again to you, Professor Hesham. So I think being a representative of the government presidential health campaigns, from your perspective, how to make quality of life an important mission and a social aim that can influence health policies?
So I think it's very, very important question. And we hear from Professor Mervat that the quality of life is not a simple matter. And as usually we said, we are treating a patient, not a tumor. So it is very important to go for all the aspects for patient care. And as you see in the strategy of the national campaign, the presidential national campaign, that it is a patient-centered approach. So it is not the tumor-centered approach, it is a patient-centered approach. So the quality of life is very, very important issue. And the quality of life is not a very simple term. but it contains a lot of issues, including the nutrition, the quality of life, the beauty of the woman, the reproductive possibility even after breast cancer treatment. So it is a very important issue, and really we are now not only the quality of life, but even the satisfaction of the patients are very important measurement now in all the presidential initiative policies and the strategies that we can measure every now and then. And also, as we said now, and which is very important, positioning of the patient advocacy group and the patient representative in every step is very important to help this quality of life issues to be usually hand in hand with the go for cure of the patients.
Thanks, Professor Hesham. And with this, we come to the end of the health literacy section of today's summit. And I would like to thank again our distinguished speakers and to show our deepest gratitude for your insights and inspiration that you've provided today. And I will leave you now with the poll to give your feedback on the content and on the usefulness of our APPIS platform to you. Thanks again, and I wish you a more successful to gain more insights and benefits from our summit today.